Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an educational grant from Genentech, a member of the Roche Group.
Well, hello, everybody. Thank you for taking time out of your day to talk about adjuvant therapy and neoadjuvant therapy for colorectal cancer. So the title of this CME event is Expanding the Actionability of Crucial Biomarkers in Your Community-Based Colorectal Cancer Clinic. I want to introduce myself. I'm Chris Liu. I'm a GI medical oncologist at the University of Colorado Cancer Center, and also want to give Dr. Sinicrope an opportunity to introduce himself as well.
Hi, I'm Frank Sinicrope. I'm a GI medical oncologist at the Mayo Clinic here in Rochester, Minnesota.
All right, and we are very excited to talk about new advances in colorectal cancer adjuvant therapy. And, you know, we make this point all the time, right, in GI oncology, that for the last 20 plus years, there has been really no major advance in the treatment of surgically resected, stage 3 colorectal cancer. And, I tell my fellows that if you're ever asked a question about colorectal cancer, just say FOLFOX, right? And that's usually going to be the right answer. And I think that's been, unfortunately, the only answer that we provided in this field over the last 2 decades. And really excited to finally present to you some really exciting positive data of the use of immunotherapy in a specific population, our population of patients with colon cancer that have deficient mismatch repair. So over the next 25 minutes, this is what we're going to talk about. And so Frank and I are going to really throw a lot of information your way, but we're going to talk briefly about deficient mismatch repair, colon cancer. We're going to talk about the methods that are used for testing, and then really dive into the data. We have really nice data in the adjuvant setting from the ATOMIC study. We're lucky to have the PI of the ATOMIC trial here with us. And then also going to talk about neoadjuvant immunotherapy for colon cancer with a niche 2. And then we'll leave some time at the end for some questions. But we're going to dive straight into it. So whenever we talk about DMMR, deficient mismatch repair, colon cancer, or MSI high, microsatellite instability high, colon cancer, we think about 2 things mainly, and that is, of course, Lynch syndrome or HNPCC, and this is due to mutations in one of the mismatch repair genes, the MLH1, MSH2, MSH6, and PMS2, and/or EpCAM. And of course, we know, right, with Lynch syndrome and HNPCC that there's an increased lifetime risk of colorectal, endometrial, stomach, ovarian, and some other cancers. And this is a germline hereditary syndrome. And we know that all patients that have Lynch syndrome have MSI high or deficient mismatch repair tumors. But there is a subset of MSI high or deficient mismatch repair tumors that are acquired. And so this is a lot of time due to hypermethylation of the MLH1 promoter, and that silences the MLH1 gene. And you can also have a double somatic MSI that's caused by mutations in both alleles of an MMR gene. And so again, all Lynch right, is MSI high, but not all MSI high is Lynch. That's what makes this such a great screening test for Lynch syndrome. But of course, there can be acquired MSI as well. There are 3 methods for testing, and we really want to just drive home the fact that this is extraordinarily important to get this data from your patients very, very quickly. There are several ways to do this. IHC is likely the most common one that you're going to have at your institution. We have that here at the University of Colorado. I'm sure Frank at Mayo Clinic as well. And that just looks for loss of expression of one or more of the MMR proteins. PCR testing is another test that a lot of pathology groups have in-house, and that's just identifying variation in genomic repeats. And of course, we actually get this information now on next generation sequencing, which is really nice. But of course, the concern that we have about getting this information from NGS is that sometimes, especially if you're sending tissue out, it can take 3 to 4 weeks sometimes to get an answer. And as you can see from this talk, that the earlier we have this information, the better. And Frank, I was just going to ask you about some of your testing patterns at Mayo Clinic and how you get this information.
Sure. So we regard the IHC as the preferred initial test And an advantage it has is it identifies the affected MMR gene, which can then direct germline testing. And when we see, MLH1 is typically lost with PMS2, but this can be germline or sporadic. So this is a situation where oftentimes we need to do further testing, and that could be MLH1 methylation testing or BRAF gene testing as well. But it's important to look at the clinical context because we know Lynch syndrome tends to affect younger patients. Sporadics are more common, older patients, more commonly women, and it's about a 2/3 to 1/3 kind of ratio. It's important to recognize also that Lynch syndrome is the most common hereditary cancer syndrome overall, about 3% population prevalence, and it's the most common form of hereditary colorectal cancer. So obviously very important to get this testing done for our patients on a routine basis. And then also now we can use it to help select patients for immunotherapy. Make a last comment that these different test modalities are all very highly concordant.
Yeah, I totally agree. And I'll tell you, right, the most common situations for patients to come into, say, a medical oncology office, it's likely after surgery, right? And surgical resections happen. So getting this information quickly so that it can direct your therapy is obviously critical in that situation. And in some medical oncology offices, you may actually see a patient prior to surgery. As you can see, there's some neoadjuvant data that may be applicable in terms of using this information. So I'll go through this fairly quickly, but MSI high has a prevalence that actually decreases as you increase in stage. So when you look at the prevalence in stage 2 colon cancer, it's around 15 to 20%. When you look at stage 4, it's a lot lower, about 4 to 5%. And the idea is that these are really hypermutated cancers. And so a lot of times they're honestly too deranged to actually metastasize. But when they do, that clone has been selected for. And sometimes when you look at the prognosis for stage 4, it can be the same, if not sometimes considered to be worse than microsatellite stable colorectal cancer in the absence of immunotherapy, obviously. But when you look at stage 2 MSI high colon cancer, the prognosis for those patients and the relapse-free survival for those patients is honestly so good that a lot of times we are not going to offer patients that have stage 2 MSI high colon cancer therapy. But as you can see, what we're really interested in is stage 3 colon cancer, where the MSI high population actually has maybe a better prognosis when you look at N1 disease, but the same prognosis if you have N2 disease. Now, there's always been a lot of debate, right, about the use of chemotherapy in stage 2 MSI high colon cancer. There's some data to suggest that maybe there's a little bit of harm by giving single agent 5-FU for stage 2 colon cancer, but it's a really, really small study with small numbers. And so a lot of people then ask, well, do patients with MSI high colon cancer truly benefit from the addition of oxaliplatin to infusional 5-FU or capecitabine? And this is data that's really nice that was published a couple of years ago showing that these patients that have stage 3 MSI high colon cancer do benefit from receiving oxaliplatin. And those are the blue lines that you see. You can see how those patients do with 5-fluorouracil alone or the combination of FOLFOX, and you can see that they are getting that disease-free survival benefit.
And Chris, I would just comment quickly that that is retrospective pooled analysis data from the Accent Collaborative Group. We don't really have good prospective data on this question, but this is quite a large number of patients, and certainly I agree with your interpretation here.
Yeah, absolutely. And so I'm going to move very quickly in terms of some other updates in terms of adjuvant therapy. There's the recently reported Alaska study just looking at aspirin in a subset of patients that have PIK3CA mutations. And so here, patients were randomized to receive aspirin at 160 milligrams daily or placebo for 3 years. All of these patients had either hotspot PIK3CA mutations, that's group A, and group B were other somatic variants in PIK3CA and PTEN and others. And so when you look at the disease-free survival of those patients receiving aspirin compared to placebo, you actually see these hazard ratios of 0.5 or 0.6. And so, one of the updates that we certainly want to provide, in addition to what we're going to talk about with immunotherapy, is the fact that we should be offering patients that have PIK3CA mutations and resected colon cancer aspirin. You can see here an improvement in disease-free survival. When you look at the adverse event rate, there are more bleeding events, right, when it comes to aspirin versus placebo. But having said that, there's a significant disease-free survival. This actually now appears in the NCCN guidelines, right, in the patients that have resected colon cancer and have had received their adjuvant therapy. the recommendation is if you do have a patient with PIK3CA mutation, to go ahead and add in that aspirin at 100 to 160 milligrams daily for 3 years. I will also mention that there's a challenge study that was presented by the Canadian group showing a 6% overall survival benefit in patients that had essentially increased their exercise to where they were exercising about 30 to 40 minutes a day. And so my question is, right, should we be hiring more personal trainers, giving less oxaliplatin? I say that in jest, but it really just proves how important exercise is. And really, the testing for PIK3CA is something that really traditionally hasn't been done. We actually have data suggesting that we can intervene on these patients and improve their disease-free survival. Frank, any comments on this?
No, I mean, certainly we would need, next generation sequencing to be able to identify these patients. And we know this is not currently approved by insurance in the non-metastatic setting. So this is some issue that needs to be further addressed going forward. This study that you refer to here, the Alaska study, included patients with stage 2 and 3 colon cancer. And the data is quite impressive, as you showed. And I do think we have to be cognizant, as has been shown, that aspirin is not without side effects. We do have some concerns in elderly populations, so we need to keep those factors in mind. But very impressive data.
Yeah, absolutely. And, it should be noted, to your point, that we're seeing right around a 10% disease-free survival benefit, but also a 5% increase in serious adverse events, which we assume, obviously are more related to bleeding. But that leads us into immunotherapy. And so, Frank, take us away.
Okay, so I'm going to discuss the ATOMIC trial, which will be coming out in the New England Journal of Medicine in the next few weeks. But this trial looks at the addition of atezolizumab, an anti-PD-L1 antibody, to standard FOLFOX chemotherapy for patients with stage 3 DMR or MSI-high colon cancer. And this was a randomized study where patients had to be at least 12 years of age, had to have histologically confirmed stage 3 R0 resected adenocarcinoma, and the DMR status was determined by local testing. We also have retrospective confirmation of that testing. Patients had to be previously untreated. You can see the stratification factors here. They were enrolled within or at 10 weeks after surgery. And you can see the randomization of 1-to-1 to modified FOLFOX6 with atezolizumab for 6 months concurrently. And then the atezo is given for an additional 6 months. So a total of 1 year of adjuvant immunotherapy compared to modified FOLFOX6 alone. Now, this study was developed before the IDEA study was reported. So the study was too far along for us to modify it to look at the 3 versus 6 month treatment duration. The study primary endpoint was disease-free survival, and secondary endpoints are shown here. The target accrual for the study was 700 patients. We actually enrolled 712 patients, but you can see the baseline characteristics are very well balanced between the study arms. The median age is in the mid-60s. You can see a very similar proportion of T4 and N2 tumors, and therefore, and there's a slight increase in patients with the high risk as opposed to low risk patients in the population. At the second interim analysis of 75% of events, the study was stopped by the DSMB, and you can see that the combination with atezolizumab, 86.4% 3-year DFS, 76.2% for FOLFOX alone. This is a hazard ratio of 0.51, so roughly 49% reduction in recurrence and death with the addition of atezolizumab to modified FOLFOX6 at three years. And you can see the survival curves diverge very early, and this separation is maintained over time. If you look at the forest plot here for different subgroups, you can see the benefit is achieved across all the subgroups that were examined in this study. And you can see in particular the high risk and low risk patients benefit as well. Looking at safety, there is an increase in grade 3 and 4 AEs in the FOLFOX atezolizumab combination compared to FOLFOX alone. And there were deaths in this study. There was 2 treatment-related deaths in the atezo-containing arm and none in the FOLFOX alone arm. These deaths included one sudden death and one sepsis, and were considered possibly related. All other deaths in either arm were judged to be unrelated by the study investigators. And if we look at the particular adverse events, this is occurring in 20% of or more evaluable patients. We can see that fatigue, nausea, and peripheral neuropathy were the most commonly observed adverse effects. But when we look at grade 3 and 4, which are the darker colors, the only real increase that we noted stands out is the fatigue going from 4 to 10%, and not so much difference in neuropathy. And the neutrophil count decrease was greater in the atezolizumab containing arm. So that was manageable non-febrile neutropenia. But overall, pretty much side effects in line with what would be anticipated. And this looks at the potential immune-related adverse events. So it's important to point out that with the addition of atezolizumab, we see more in the way of hypothyroidism, hyperglycemia. There's maculopapular rash also. But when we get into looking at grade 3 or 4, we really didn't see any clinically significant differences in the more severe adverse events in this study. So takeaway points from that: we have typically and traditionally been treating patients irrespective of MMR status with FOLFOX and CAPOX for all stage 3 patients. Atomic shows that adding atezolizumab to FOLFOX significantly improves disease-free survival. And so we regard this as a new standard treatment for DMR stage 3 colon cancer patients. And the NCCN guidelines have adopted the Atomic data. And the interesting thing is that they have recommended that both FOLFOX and CAPOX can be used in combination with atezolizumab. And also they expanded or extended our results to a population we didn't actually study, but that is the highest risk stage 2 patients, the T4B N0s, and they recommend the consideration of fluoropyrimidine therapy with atezolizumab.
Yeah, and Frank, I was going to ask you, what you thought about that, the idea, right, of because I think this comes up in clinic all the time. We all get these patients that have MSI high T3N0, right, disease, and even though they're oftentimes poorly differentiated, right, because these are hypermutated tumors, a lot of times we know their prognosis is outstanding. We're usually not going to give adjuvant therapy in that setting. But what do you typically do with these T4Bs? Because I think this is a very common clinical scenario where you have a locally invasive tumor. You're worried, obviously, about micrometastatic disease. Tell me what you think about adjuvant therapy in that setting, and then obviously the addition of atezolizumab.
Yeah, I think that the T4B is the subset of N2 that we've always seen has the worst prognosis of stage 2 patients. They tend to do like stage 3 or even worse. So I treat these patients with their DMR if they're T4Bs, with immunotherapy. And then we'll get into the niche study, of course, which raises the question of, do we treat them neoadjuvantly or do we treat them adjuvantly? And we can discuss that further. We don't really have data on capecitabine with atezolizumab, but of course we're extrapolating because we regard them as relatively equivalent therapies. One may ask, do we need chemotherapy, or what's the duration of chemotherapy? A pre-specified analysis that we did showed that the patients do best if they have at least 3 months of chemotherapy with the atezolizumab. So this is very interesting because we thought in the beginning that we had to include chemotherapy, but we probably don't even need it. But interestingly, the data suggests that chemotherapy may be providing some benefit here in addition to the immunotherapy.
Yeah, totally agree. And answering that question about 3 versus 6 months, I think is really, really nice. And so obviously, as that data comes out, I think it will help continue to guide practice, because I'm sure there are a lot of providers that are asking this question. If somebody has T3N1 MSI high stage 3 colon cancer, do I really need to give the 6 months of FOLFOX? And I think that you'll be able to provide that answer. All right. Well, thank you for that, and for the presentation on Atomic. And I will also tell you that I think, as more and more of our providers here, and even my referring providers, have experience with FOLFOX and atezolizumab, the tolerability has really, really been great. And I think we always obviously worry about the peripheral neuropathy with oxaliplatin. It is really, really nice to see that there are no overlapping toxicities there. So really, really important to show that toxicity data. So thank you, Frank. Okay. So then, we've talked about what we do on the back end, right, with adjuvant therapy. We do want to present some data in the neoadjuvant space. And so the niche two looked at a short course of immunotherapy prior to surgery for patients with locally advanced mismatch repair deficient colon cancer. And this is a phase 2 study, right? Single arm phase 2. Again, patients with stage 2, stage 3, they did try to select for higher stage tumors here. But in the arm, the patient received 2 doses of nivolumab on days 1 and 15, so 2 weeks apart, and just 1 dose of ipilimumab, and then surgery was to be performed 6 weeks after they enrolled. And so the primary endpoints was to make sure that they weren't delaying surgery a ton by doing this, but also looking at 3-year disease-free survival with a secondary endpoint of pathologic response to the immunotherapy. So you can see here, when you look at the patients, and this is obviously a much smaller study than what Frank showed to you, Atomic was 700 patients, this is 115 patients, but still a good number. They really were selecting for higher grade tumors. There's a high percentage of T4A, T4B tumors, as well as node positive tumors. And when you look at the result of giving the 2 doses of nivolumab and the 1 dose of IPI prior to surgery, you see this really impressive major pathologic response rate of 95%, and 2/3 of the patients had a pathologic complete response. And again, these are in locally advanced MMR deficient colon cancers. And this was reported about a year and a half ago. But there is 100% 3-year disease-free survival. And I should also note that very, very few patients, like just a couple of patients, actually received any adjuvant therapy. So the entirety of the therapy that they received was mainly just the 2 doses of immunotherapy. And so this really kind of begs the question, and this is certainly something that we can talk about, but we have this great, adjuvant data with Atomic. We do have this really impressive neoadjuvant data now with neoadjuvant immunotherapy. And so what do we know, right? What has niche 2 taught us? The study really has taught us that we can achieve a lot of tumor downstaging with just a little bit of immunotherapy up front. And we also know that, it's tolerable, although we know that there's going to be some immunologic, therapy related side effects, even just to the 2 doses of Nivo and the 1 dose of ipilimumab. But of course, there's no chemotherapy, right, on the adjuvant, back end. Of course, this is a non-randomized phase 2 study. And so it's tough to make, a lot of firm conclusions based off of this study, but it is 115 patients. And of course, a lot of this is really dependent on your ability to accurately stage these cancers with radiographic imaging. And so I think part of the issue is that if, we can make the assumption that this looks like a T4 lesion or there are a lot of nodes, but we don't necessarily know that if you have nodes that are slightly enlarged around a cancer, that those are cancerous lymph nodes. And so one of the concerns regarding a neoadjuvant approach is that if you actually have a stage 2, right, colon cancer, and you're treating them with immunotherapy up front, there is the potential to accidentally overstage the patient and potentially overtreat them as well. And so when you look at how NCCN has kind of digested all of this data, Frank showed you the data on the adjuvant side. This is on the neoadjuvant side. So in patients that have DMMR or MSI high colon cancer, and you suspect that they're either a T4B, right, from your radiologic imaging, or if you have bulky nodal disease, that, obviously you can consider chemotherapy, but up here, the addition has been to consider neoadjuvant therapy with a checkpoint inhibitor immunotherapy preferred. And so what's not necessarily defined within the NCCN guidelines is what you give here. I think the niche trial obviously used Nivo and IPI, a combination, but we know that there's experience with single agent immune checkpoints inhibitor, and MD Anderson has had some nice data in the colon cancer setting as well. Sloan Kettering has great data in the rectal cancer setting. And so the question really is here, patient selection. And really we'll ask Frank, to weigh in on this in terms of how you kind of see the neoadjuvant side of treating these patients.
So a couple of comments. I mean, to amplify on what you were saying, it is true that DMR tumors have more lymph nodes, and they tend to be a bit larger, and the radiologic literature is certainly showing this. So there's definitely potential for overstaging. But we know that we do encounter some of these tumors that are bulky. They're involving perhaps the anterior abdominal wall. And where if there's a concern about R0 resection, then then it's an attractive strategy to downstage to facilitate a curative surgical resection. So I think it's that subset of patients that have bulky tumors where we're worried about R0 resection that we really need to think about neoadjuvant therapy. I think, the pathologic complete response rate is very impressive. And I think it's important to realize that having an intact primary tumor and all of those tumor antigens is likely important to the great response that we see with neoadjuvant therapy. When we do surgery and take out the tumor and all these regional lymph nodes, we may be compromising the efficacy of immunotherapy to some extent. And I think that's an important research question going forward that we'll need to address. I did want to make a comment also. This slide shows this POLD1 mutation group. They're a small subgroup of a few percent, but they're ultra hypermutated and they respond extremely well to immune checkpoint inhibitors. So just mention that kind of as an aside.
Yeah, I think one of the difficult things that I found with POLE and POLD is that unless you can get that NGS back pretty quickly, you're more likely to be dealing with them more on the back end after surgery, as opposed to trying to make a neoadjuvant, therapy decision. And
Yes.
again, this really speaks to the importance of the IHC or PCR testing, whatever you can get back within 24 to 48 hours. I think, obviously with adjuvant therapy, you have time. With neoadjuvant selection, because you don't want to delay surgery too much, and you want to get started as quickly as possible because of that, getting this information to deal with this particular scenario, really bulky nodal disease, T4B. One question I was going to ask you, Frank, was I had a patient recently that was, almost obstructed, right? And we knew that they were MSI high, prior to surgery. And, for these patients that have either are obstructed or nearly obstructed, that's a situation where we really worry, right, about taking time to start any treatment, just because it takes time to get anybody like either a port or IV access or even get insurance approval for particular drugs. Is that a situation that you've dealt with? And would you have a recommendation to either go straight to surgery or try this immunotherapy approach?
Yeah, it's kind of there are patients, yes, where, as you say, where they have tumors that seem to be obstructing at the ileocecal valve. And some of those patients, we know we can give them some immunotherapy in just a couple of doses and probably open them up and a lot, which facilitates their subsequent treatment. So I think it's an important strategy. I think we need to use it, somewhat selectively, but it definitely has a role in our armamentarium in these patients. And we're as we're saying, Atomic is phase 3 data. We're very comfortable. It's very robust, but there's definitely a very important efficacy we're seeing here, but we need to use it strategically, I think, going forward.
Absolutely. And one last question, for those T3N1 patients that, are MSI high, any recommendations in terms of duration of chemotherapy based off, obviously, your own personal experience, but on the data that you have as well?
So they need at least 6 cycles of FOLFOX chemotherapy. I think that's kind of what our analysis is showing. I think we could say that at this point. But I wouldn't want to take the perspective that we really don't need any chemo and that we can just give a couple of cycles and stop. That's not what the data shows. The data shows they need at least 6 cycles of treatment.
Yeah, that's great advice, and actually important for me to know too, right? I mean, because we always do have that question of like, maybe we could just get away with immunotherapy alone, but I think the importance of giving that chemotherapy, at least for 3 months is just a really, really great take-home point. And then obviously after that, you're probably guided mainly by the risk of the disease, and obviously how the patient is tolerating their chemotherapy as well.
Right. And I think, certainly we all want to avoid long-term peripheral neurotoxicity. And if patients are developing that during our treatment, then of course that's a trigger oftentimes to dose reduce or eliminate the oxaliplatin earlier than the 6-month duration.
Great. Well, I just want to say thank you to you, for number one, obviously for the great presentation, but also for the data for atomics, and hopefully you guys have found this very helpful. It's just exciting to finally talk about new drugs in the adjuvant therapy setting. So appreciate you all taking the time.
Thanks very much to you, Chris, and to the audience for this very informative session.
Thank you, everybody.